Hasbrouck is the medical director of HealthInsight. He is on the board of directors of the Utah Comprehensive Health Insurance Pool and is also a commissioner on Utah's Digital Health Services Commission. He served on the board of directors of the Utah Health Information Network, UHIN, and as a Utah State Health Data Committee member in the past. Dr. Hasbrouck has over 20 years of clinical experience. Dr. Hasbrouck has served in executive leadership roles with the Hospital Company of America, United Healthcare, Regions Blue Cross Blue Shield of Utah, and the Regions Group. He's a diplomat of the, did you say that, diplomat? Of the American Board of Internal Medicine. He's a graduate of the University of Minnesota Medical School and completed his residency at the University of Utah. And thanks for being here, Doug.
Sure. So where's the clicker?
The clicker?
I just had it.
Did it get, oh, it's
So thanks for allowing me to be here. So I decided to, so this is project management seminar, and the ACA in and of itself and implementing it is probably the hugest project known to mankind. And so I've been involved in one piece of the implementation over the past few years, which is the pre-existing condition insurance pool, and thought I'd just use that implementation as an example of some of the issues that will be coming into the insurance market and how some of these mechanisms of changing care and data flows and changing payment designs might come into play for these new people that are being insured. So let's see. So just relevant to this, so I've served in executive roles in two insurance, in both United Healthcare as well as Blue Cross Blue Shield Regents, and have experience with commercial insurance populations, Medicare and Medicaid, so government programs as well as commercial programs. And I've served with this, with Utah's state high-risk pool governing group for 15 years and have been on their executive committee for 9 years. So the experience that I'm going to talk about is really specific to that time on the high-risk pool. And then I've served in other executive roles. So my personal view is kind of similar to, Doug, what you said, in the sense of, you know, the ACA is a law and it's being implemented, and you know, you can go into the politics as to whether it's constitutional, et cetera, but from the point of view of this discussion, it's being implemented. And in my personal view is that the status quo system that has been in place is not sustainable and was not sustainable. And we've already been seeing, you know, the deteriorating insured system go into a steady decline, because what happens is as you get higher demand for services and unit costs go up, and the higher demand is because our population is getting older, and plus there's lots more stuff that we can do today than we could 10 years ago, 20 years ago, 30 years ago. So there's treatments that were not previously available. And these things cost a lot. It costs a lot to both capitalize the infrastructure as well as to train the people that can do these high-tech things. So that leads to higher insurance premiums. The higher the insurance premiums, more people decide to go uninsured. As people are uninsured, they still get care. We know that. They go to emergency rooms. They end up in hospitals. That write-off of costs has to be shifted to the insured population, which means the insurance premiums go up further, which means there's even more uninsured, which means there's even more cost shifting. And you can see that pretty soon you have a smaller and smaller insured population, you know, paying the bills. So
at the Alabama game, we called it around the bowl and down the hole.
around the bowl and down the hole.
Roll Tide.
Right. So any politics you have, if you don't realize, you know, the root cause of the problem that is trying to be addressed, you have to, in my mind, you have to come up with a different solution than what's been in place. So, but I will also say the Affordable Care Act is not perfect. There's issues, and there's going to be a lot of unintended consequences and things that happen that it's going to need to be fixed on the fly. And again, Doug talked to some of those. So things that I want to talk about just a little bit is risk management issues, meaning as you no longer can underwrite people and see what their risk is coming in and set premium based on that underwriting, and as you can no longer not insure people because of pre-existing conditions, you're bringing a lot more risk into the marketplace. And I'm going to show you a live example of that in the federal high-risk pool. It was a natural experiment the last 2 years. Then maybe I'll talk some things about system accountability systems. That's a double. But really, as you guys have been hearing about the Beacon Project and about patient-centered medical home and about payment alignment, really that's what the system accountability idea is. So you've heard a lot about that, and so I'll probably skim over that. And then basically the needs for even better data to support this kind of system. So in terms of high-risk pools, just some background, most states have developed high-risk pool insurance mechanisms. I think about 40 states have these. Utah's has been in place since 1991. So there's I guess 4 basic markets for insurance. There's government-covered insurance, which is primarily Medicare and Medicaid. Then there's large group insurance, large employers that do their own thing, like your company. Small group, 1 to 100 is typically small group. And then the individual market. And the individual market is the one that's really most impacted, individual as well as small group, but really the individual group market is the most impacted by the ACA. The individual markets have been problematic for forever, which is why these state-based high-risk pools were put into place. They're basically mechanisms to give some insurance coverage to individuals. A lot of these people are self-employed, or they're retired, say at 60, and it's 5 years before they're going to get to Medicare. So they have to have an individual product. But there's a lot of risk in individual insurance. So mechanisms that were used is to define subsets of the population as being uninsurable, and there's actuarial definitions to that. And these high-risk pools are subsidized by the state to make the premiums more affordable. It basically keeps the commercial market individual plans with younger, healthier people, and so the premiums can be lower, and so that those younger people will buy insurance and take some of the risk out of the market and segregates it. But even with that, this pool in Utah allowed immediate coverage. If somebody had continuous coverage and they just came off an insurance plan with their employer, now they retired or started a business, they could come on to the HIP pool immediately and get claims paid from day one. But for people who had been without coverage for a period of time, a 6-month pre-existing condition coverage exclusion was in place. And these 6 months exclusion periods was basically to prevent people from getting a diagnosis of cancer today and then going out tomorrow and buying insurance. It was basically to say insurance is something that you buy for a problem that you don't know about yet. And so we're going to create this exclusion period to cause people to know you can't wait till you're sick to come get insurance. It's kind of like buying house insurance when your house is on fire. It's the example that's used. Well, so as of January 2014, the whole notion of waiving, not being able to provide insurance coverage for somebody with a pre-existing condition, that goes away by law. And So what the insurance company said was, okay, January 1st, 2014, we're going to have all this pent-up demand of all these really sick people that we're going to have to insure as of January 1st. That's going to be a huge bunch of risk coming into our plans that we aren't going to be able to do. So this idea of a federal pool for 2.5 years to take some of that pent-up demand out of the system prior to January 1st, that's what this federal high-risk pool, why it was created. So for this plan, so in Utah, this started up September 2010, so it's been in place about 2.5 years. There's no pre-existing condition waiver. You don't have to have had prior coverage. So the system is similar to what will be in place in 2014. And this is telling you about to mitigate against pent-up demand. And so I'm going to show you some data about what happens in these pools. This is experience from September 2010 through May 2012, but I can tell you that this experience since then has been similar. So I hope you can see this. So this data was actually as of I think this was May 2012. And the enrollment at that time was 650 in the federal plan and almost 3,700 in the state plan. So remember, the state plan has been in place for 22 years, and it excludes pre-existing conditions for 6 months. So you can't have a diagnosis yesterday and get insurance tomorrow. This plan, you can have a diagnosis yesterday and get insurance tomorrow. In terms of the demographics, the male-female mix was about the same. But females of childbearing age, you can see 13% of enrolled in the state pool, almost twice as much in the federal pool. So a fair number of people that we're seeing are people that were uninsured. They get pregnant and they apply for the insurance to get coverage for the pregnancy. Again, of childbearing age, percent of females, 23% on the state pool, 42% on the federal pool. It's a younger population on the federal pool. It's also it's a lower income population. So a lot of the people on the federal pool or the state pool are people, I mean, a lot of them are professionals with their own private businesses. I mean, it's doctors, lawyers, dentists, architects, insurance brokers. And the other group is people that have retired early, so they have some wealth allowing them to retire early, and they're needing this for coverage. So you can see that the average household income is $82,000, whereas in the federal HIP pool, it's more like $42,000, median household income $50,000, and federal HIP pool about $32,000. So reflect on these numbers in terms of Doug's premium subsidy. These folks don't feel like they can afford insurance until they get sick. And the percent of income less than $30,000, 40% of these people were in that demographic. So then this tells you what the price of not having an exclusion, a pre-existing condition exclusion is. So the average cost per member per month, so cost of covering people in the state pool was, and this is from September 10th through December 11th, so it's the same time periods for the two pools. Average cost is $720 basically for the state pool.
Is that for an individual?
Yeah, per person per month.
Per person per month.
That's their cost of care. Whereas the federal HIP pool is almost 4 times that much, so $2,800. And for the people who had been on the enrollees who had been on the plan for less than 6 months, this cost was $6,000 per member per month. And I'll show you the graphics that give you even a better sense of this. And the other thing that's interesting is if you already know you're sick and you're going to consume quite a few healthcare dollars, you're going to buy the lowest deductible plan. So you can see the distribution of people going to the lowest deductible, whereas for these folks, they have conditions, which is why they're in this pool, like diabetes, hypertension, heart disease, but almost half of them chose the high deductible plan.
Is there a subsidy?
There's subsidy for both plans. The state plan, about a third of the cost is covered by the state. The federal plan, about 80% is covered by the feds. So basically what this shows is that the people on the state plan that were using this for actual insurance, they tended to stay on the falling off of enroll. This is how long they stayed enrolled on the plan. They gradually declined, and some of these people get jobs where they have insurance coverage. Some people become eligible for Medicare, so they fall off. Whereas in the federal pool, people fell off, quite a bit more rapidly, which again kind of shows that they're using insurance to cover the immediate need, and then once their need was met, they disenrolled from the plan. And this shows average claims per enrollee by month on the plan. So the first month, so the federal is the red. The first month on the plan, the average claims were 6,500, whereas here there's this pre-existing condition. People have either had existing insurance and they're coming on this, so they didn't have a bunch of pent-up demand, or they had the exclusion for pre-existing conditions. And so you can see that those claims actually stay, fairly stable and are fairly predictable, whereas a significant number of claims costs occurred in the first 6 months. And you can see the longer they were on, they actually started to look more like the state high-risk pool. So my summary here is that there has been a high-risk pool to allow people to have coverage that's fairly affordable. I mean, it costs me about 20% more than a commercial plan. It's subsidized by the state. But the demographics between the two pools are clearly different. Younger and less income on the federal pool. There's a subset of federal pool enrollees that clearly are not really using it as insurance. They're using it for an immediate need, and once that need is met, they're dropping off. And I think this information does have implications for the successful execution of the ACA in 2014.
What does the network look like in the Fed versus the state?
It's the same.
Similar?
It's exactly the same. It's the select.
Or
It's
subset of?
It's the Select Health. We use Select Health as the administrator. Yeah. So the benefits are the same. The network is the same. So everything else is pretty controlled. So the federal government, as this ACA was put into place, they kind of knew this was going to happen, and so they knew there was concerns about it. One of the ways that they're trying to mitigate against this is what Doug presented as far as making it, trying to entice people to getting covered early, not waiting until they have a condition before getting coverage. So the premium subsidies are meant to do that, and the penalties are meant to do that. The penalties the first year is only $95 though for an individual, but it goes up to $700 for an individual, or 2.5% of your income by 2016. So,
Per year?
That's per year. So between if you have a subsidized premium that's relatively affordable, and then you're looking at having to pay a penalty, the difference between what you're paying and the penalties does start to go down, such that hopefully a rational person would say, well, I'm better off buying insurance and having coverage. But there will be people that won't. We know that. So some of the mechanisms to mitigate against this influx of risk into the market. Because if that all just came in and the insurance companies had to just absorb that whole shock, premiums would just go through the roof. That's pretty clear. Premiums may go up anyways, particularly the first few years. What a lot of people think will happen, and I kind of think will happen, is that the premiums will go up for a while. You'll get the benefit of not having cost shifting, which is creating a lot of imbalances in the market right now. That'll be distributed. In 3 to 5 years, this stuff will all have gotten absorbed. Right. Mm-hmm. And then costs, I think, will stabilize or maybe even come down at that point. So there's basically 4 main mechanisms to try to mitigate against this risk. One is called reinsurance. So all of the pools, all of the health plans that are will be participating in these pools, like on the exchange, taking on these new members that they didn't have to have previously, will have basically a cap placed on individual claims. So if you get a person, and I don't know where the reinsurance will come into play, but just for example's sake, I'll say that the reinsurance level would start at $200,000. So if you had a member and they got to $200,000, the health plan's liability would stop at $200,000 and it would shift to a federally paid for reinsurance pool. So it basically helps to put a cap on individual large claims. The second is that there will be risk adjustment mechanisms. And what will happen there is, as Doug described, there will be an analysis will be done. Average expected cost per person will be established. There'll be a community rating. If a health plan, because of certain characteristics, attracts higher risk people, so say people perceive the university as having the high-end care and they want to network with the university, and so you might attract more risk than the average into that. And another plan might attract low risk. Within a market, the low-risk people will have money taken away from them, and the people that attracted high risk will have more money given to them. So there'll be a risk adjustment within the given market. And then there's also a mechanism that are called risk corridors. And as these guys have talked about, they've developed plans. They've submitted to the government. Here's what our plan is. Here's what we think it's going to cost. Here's our rationale. We think it's going to cost this. The government's accepted that. If they do worse than expected, the government will prop them up after 3 percentage points. But if they do better than they thought, the government's going to take that extra money, so above 3 percentage points. So basically, I guess I'm saying the insurance companies are taking on more risk, but there's a fair amount of mechanisms to absorb that risk. Some of these mechanisms, this reinsurance will go away after 2016, because again, that will have allowed this population to get in, and people should be able to price for it. The risk corridors will go away after 2016. The risk adjustment mechanisms will stay in place permanently. So the last piece that I was going to just talk about is another mitigating tactic is this whole effort around providers. And so this is what you've been hearing about the last few days with Beacon and people talking about patient-centered medical home, et cetera. So in order to take on all these additional people, take on this additional risk, trying to set up systems that create better access, provide quality of care at lower cost. That's what folks are trying to do. And technology implementation is a big push on that to understand data and have data sharing so they decrease duplication. The whole idea of meaningful use of electronic medical records, the government's been subsidizing primary care docs to get medical records and to learn how to use them. Again, that's what the Beacon Project was about. The insurance companies will be able to work with these kinds of networks to have better information sharing between claims and clinical information. And this will allow, as Doug called it, pay for value rather than pay for volume. So I'm going to end with that. You know, my summary is that the Affordable Care Act is going to make big changes. Some of the changes it's going to be like your burger, Doug. Good, bad, and maybe a mess, and some of it, you know, it's a good image, I think. And, but I think folks, there's been some experience that help people to understand some of the potential impacts, and there's things in the law to help mitigate against that. So those are my comments. Any questions? I know, we're gonna be done early.
Which HIP program just quit accepting the state?
That was the federal pool. So this is interesting. So for the federal pool, this federal reinsurance pool, that high-risk pool that I was describing, in the ACA, $5 billion was allocated. And when it was set up, that $5 billion was to provide coverage for basically 3 years, and they thought it would cover 300,000 people. Well, it's actually covered 100,000 people, and they've run out of money, so they capped enrollment. Well, they haven't totally, they've got a little money left, but they capped enrollment earlier in the year, and now they're taking the management away from the states and taking it to the feds, partly because what they're going to do is cut everybody's pay. I mean, they're going to implement Medicare rates and do a bunch of draconian stuff.
There's the lesson.
Well, no, and so that's what I say about, you know, the ACA. It has good intended goals. You know, I think because it is partly political. Yeah, and people wanted to paint a rosy picture, and you know, when they said it'll cover 300,000 for this $5 billion, they assumed that people would use it like regular insurance. You know, they buy it and stay on, which means you have a mix of risk. But the truth is that what's happened is people used it for short-term coverage of needs, and then
Now Hasbrouck is running away.
right. So, you know, I think we'll have other things that we learn about how, you know, about this. But I think that it'll move us off the dime in terms of getting us away from the current system.
What did you think about that article in Time?
Bitter pill? I thought it was right on.
Yeah. I mean, it just seems to me, I mean, I've only been at this for 6 months, but it's just a big arms war.
It's an arms war.
Yeah. Prices go up, insurance companies match it, not quite as high. I don't know what's going to stop it unless there's price controls. I just don't know where it's going to go.
Yeah, it'll be interesting if, you know, whether the exchange markets work as intended and create some competition. I think that there likely will be price controls. And I say that partly because of this federal high-risk pool example. Because when the money ran out, I mean, I've been on this board. I've been, just even in the last 2 weeks, trying to negotiate it staying in Utah. And we came up with proposals to mitigate price. And at the end of the day, they said, well, that's all too complicated. We're just going to take it all back, and we're just cut fees. And so I think that, you know, I think there's a real danger that becomes the solution. So we'll see.
I have a really basic question that I'm still unclear on. A lot of the talk that's gone on the last 2 days, one of the reasons you all were last was we talked about you a lot. But everything hinges kind of on this shift in the whole payment system, the pay for value. And I haven't quite wrapped my mind around how exactly is that going to work?
Well, there's a lot of different models, I guess you would say.
You could start with whatever your
live on a fee-for-service chassis right now. The question is, how do you get away from it? It would be nice if Medicare would move and the proposed SGR fix that they had was implemented where they might start migrating away from fee-for-service. I mean, that would throw a big block of people in the market that would be paying more for value. We have our own, we're going to start with fee-for-service. That's what there is. That's what the providers know. That's what's administered. As we build our population of insured and are able to drive those members to a narrower set of primary care providers and then secondary care later on, the hope would be that we can influence their practice more, right? As they get more membership, that would be ours, and they would be able to unattach themselves from a fee-for-service. I think the payers need to understand that it costs more to provide primary care services that unlock the savings and the quality of the system. Estimates have been upwards of 30% investment. There's a internist at Harvard by the name of Alan Gorel, and his work is based on risk-adjusted capitation, and they estimate that it's about 30% more to build a medical home that works well. And by doing that, you'd then be able to deliver all the services needed to then manage the care appropriately. Dean Health, like I said, if anyone wants to pay $400 to watch a 3-hour discussion of how they did it at Dean Health in Wisconsin, you can do that. Or for a month, we've come over to my office and sit on a computer in the office and you can watch it. But they talked about how they redesigned primary care with lean healthcare processes and aligning incentives based on value. They've done it. Within a 4 or 5 year period of time, they've cut 25% of their medical spend. What they found is when they did an analysis of how much their health plan, they're integrated, they're like a mini IHC. They're about 300,000 members in Wisconsin, and when they looked, they were total 97% of what they were paying docs was RVU based, so fee for service. They changed the mode. They said, are we going to be value or volume driven? And they said half of our members are our own health plan and half are fee for service. So are we going to be schizophrenic is what they said? Are we going to have 1 foot in a canoe that's fee for service and 1 foot in a canoe that's value? Or are we going to put both feet somewhere? They decided to go all value driven. And so how that changed is they still incentivize efficiency, is what they call it, with RVU, but it's a smaller percentage of the total, a vastly smaller percentage of the total. And then they started paying for a panel of patients. You have 2,000 patients and they tied the reimbursement to age and sex. So a 65-year-old woman would cost more than you'd get more, take care of her than a 21-year-old man. And so they pay for the panel. And then they would pay for outcomes and quality. And so there were incentives now to take care of a group of people well. And by the way, do it efficiently. Okay, that's where the fee-for-service came in. And when they started this, 6% of their total healthcare spend in their system was sent to the primary care. 94% was somewhere else in the system. But then they did a secondary analysis. What influence
So the other thing, I mean, that I can mention along that line is, so as a state, Medicaid went to a accountable care organization methodology of payment as of January 1st of this year. So the 4 counties in Utah that have 75% of Medicaid enrollees, which is Salt Lake County, Davis, Weber, and Utah County, those 4 are now on basically a capitated payment mechanism, which, and not only has the risk been shifted from the state to providers, there's by state law, there's a cap on how quickly their payments will rise year to year. I think it's like around 2%. It's going to be tied not to the healthcare inflation factor, but to general CPI. So if people don't start to figure out different ways to manage, that pressure on those systems is going to come on very quickly here in the next couple. It's already started, and the plans are starting to think about doing things differently. I mean, I think the whole movement towards patient-centered medical home likely is going to be accelerated by this Medicaid shift in payment. So the status, I mean, the status quo, it's very easy to stay in the status quo for healthcare, both on the insurance side as well as on the delivery side. And I mean, that's kind of where I started in terms of my personal view, that the status quo is unsustainable because people have gotten comfortable with it. It's created a result. Unless something dramatic happens to knock people off that course, you're going to keep having the same thing you've had.
It's going to be interesting. A friend of mine's an obstetrician, and I was telling him what I was doing. And, he said, "You're not going to capitate us, are you?"
Right.
Darren, someone's going to.
Right.
Well, that's the thing, is that
Someone's going to.
you start these
eventually.
networks with groups of docs that see the writing on the wall. But they can't get, leadership can't get everybody to buy in. So they have agreed to start managing their patients more aggressively. They don't lose any money. If they do as well as they think they can, they get paid fee for service, and there's a withhold. Withhold comes back when mutually agreed upon criteria are met. And if there becomes an argument where those criteria don't seem to work right, you can renegotiate. And so the first few years, the docs don't lose money. They just learn how to do it. And then the old guys like me retire or die off. and the young people coming in who have been more inculcated with this theory will be more comfortable about taking on more and more risk. I mean, the problem with the old capitation model, it had nothing to do with quality, or at least not a lot, other than what was driven by docs themselves, because it just wasn't measurable. Now it's a lot more measurable. And so you can actually call it paper evidence, but you're gonna, what I think is actually the deal is eventually these are all going to be capitated plans, and they're going to have to show good quality. And because there's no price controls on urgent cares, no price controls on ERs, and the more and more risks these docs take, they're going to expand their hours more and more to compete. I mean, we had a proposal from an urgent care company that wanted us to pay them a cap. And 3 years ago, it would have been slam dunk. Sure, keep them out of the ER. We don't care what it does to the PCPs. Now it's like, that's going to threaten our high performance centers. I mean, there's no way to do that, because there's no way to, on the one hand, capitate for urgent care and compete for primary care, and then on the other hand, say, we want you to take care of all these patients. Well, you're taking all these patients away from us. So it's a big moving target.
And I'm curious with Alpheus, Coventry, Aetna, I kind of lost track of who
we're hoping that they've got some systems that are better than ours. We know we've got some systems that are better than them. That's another thing they said. So we bought you because we like your systems.
Do you have a high-performing network contract here with anybody in Utah?
With help.
Okay, with Health Utah, okay.
And, but they're sort of leaving us alone, because, I mean, the main reason for the merger is Aetna's big on national contracts. They know how to run those on a national basis, but they don't know anything about running small markets, small groups, even medium-sized contracts. They like to shy away from anything less than 200. So, and that's what Coventry has been doing. Basically, Coventry's been buying poorly performing plans for 20 years and turning them around. And Altius made money, lost money for 6 years, made money for 2 years, and got bought by Coventry.
Okay.
And the CEO of Coventry was Mike Barr, who used to run Altius, and before that he had something to do with Select Health. And so we had a relatively good reputation at Coventry anyway. So we had a purchase. And the guy that's over the west side was like, you're fine, I'll be there in a month. He has to take care of everybody else who's a little bit further, because there's some states where there's quite a bit of interplay. Aetna's got 90,000 lives here, and that's going to be interesting, because they're using IHC now. We don't. So there's going to have to be some bifurcation for a while.
Yeah. And Doug, you used to work with Region Blue Cross, and I hear some of the practices we've been working with in Beacon and RIC talk about we're already getting paid based on performance, and that's the company that usually comes up, and I just wondered if you knew what they're doing.
Well, so I know that Regents has had both pay for performance as well as medical home contracts in both Washington State and Oregon. And my understanding is that the last year they have kind of been contacting clinics like one at a time sort of thing, and starting to put those kind of contracts in place. And I think one of those models is just a straight kind of pay for performance, which is, you know, meet these goals, you get this extra money. But I also believe that they, at least one or two clinics, I think they are paying a monthly management fee, more like the medical home sort of a model. So I think there's some movement happening.
Relationship with Central Utah Clinics,
Okay.
where they're going to, I think, work with kind of an ACO type contact. And Scott Barlow, if you talk with Scott, Scott just says, look, first time he met us was, hey, just pay me, you know, we get to a point where you pay me what you did last year minus 5%, and get rid of claims, we're good for that. I mean, his push is to get rid of all the administrative hassles and things that go along with that. And so they've just stricken a
Well, you know,
who is growing aggressively across the state.
yeah. Well, so you another point that you just mentioned rang a bell with me that we haven't really discussed. It's not so much on the payment alignment side, but one of the ideas in the Affordable Care Act around these common plan designs. So to be a qualified, to be on the exchanges and to be eligible for subsidies, you have to these folks have to submit to the government that they're the design of their plans, and they get deemed as a qualified health plan, that they meet all the criteria. There's really kind of two thoughts about that. One is that if you're on this market where you're online, you know that you've got apples to apples comparison, and Doug, I know you had that on your slide, but so if plans are so very different at the detail level, you could get tricked into buying something just on low price and thinking it was the same. So part of this is having these plans be truly apples to apples. The other piece of that is that does create administrative simplification at the provider's office too, because they know this is covered and it's covered in these ways, and you know, it's not some crazy contract language that I'm going to have to go fight for my claim payment and spend a bunch of
Essential health benefits that everyone will cover with these plans that
Yep.
have to be covered.
Yep.
And then, you know, then there's some, the ones that aren't, you'll see some variation.
Yeah. But that whole piece about the cost of claims administration, like you're talking about Central Utah Clinic, them looking for mechanisms to diminish that. Yeah.
Make that simpler.
Yeah.
I think it goes a lot to patient satisfaction, you know, they go and see a doctor and, the visit may be good, but the next 3 or 4 weeks you're haggling with the insurance companies. And so your ultimate, relationship was a negative one, right? I mean, so I think from the provider side, they like some of that simplicity where let's just have a trusting relationship with each other.
Well, I mean, the other comment that I'll make, you know, again, to kind of synthesize some of the discussion, you know, that's happened over the last couple of days is, so some of this different payment mechanisms have been tried before. They were in the 1990s and they were called HMOs, and it created huge backlash by all the stakeholders. It saved money, it kept costs down, and it actually improved quality by everything that you could measure at the time. So it improved the value equation, but number one, people didn't understand it, so there was a lot of distrust, which can easily happen again. But number two, risk was pushed to providers, and they didn't have any of the tools to really deal with it. So things like electronic health records and being able to take registries and know, here's my diabetes population, which ones are a problem for me, which ones aren't, to do proactive management rather than reactive management. All of that infrastructure build in electronic health records, the things that Meaningful Use have done, the things that Beacon has done, provides training for these practices to be able to succeed in this environment. Whereas in the 90s, they were just thrown a contract and said, do this.
And then you got penalized if you.
Yeah, the whole risk adjustment.
Arches as there's probability risk.
Yeah.
That's the probability that a real sick person is going to walk in your office and you've got to manage them. Then there's technical risk, and that's what we went to medical school for. That's what we take pride in our skill set, that you give me, you know, I'm going to prove that if you send me that sick a person, I'm going to be better than the rest of the other doctors here. And so I should be able, based on my technical risk. And that's what we want to incentivize people to do, is incentivize them to be the best, and we'll send patients there. But we need to be willing, as the insurers, to take that probability risk away, because it did work.
Yep.
A lot of practices went out of business, and it was a nightmare because that split. So a lot of the older providers, capitation is the dirtiest word that there ever was. And Alan Grohl talks about risk-adjusted capitation, and the idea is that the insurance company will take that risk, and then you manage that person. Here's a chunk of money. The better your technical risk is, you'll get a different. You'll make differentially more money based on how good you manage it. So
Just have to get the providers to buy into your
to
methodology.
buy into it. I know.
But, right, but clinics like Central Utah Clinic are,
Get it?
yeah, I mean, there are groups of people that have been making strides in this state that are ready to likely be successful in these new models. Yeah.
The other.
All the risk was put on the doctors,
A
and
lot of risk was transferred to the doctors, yeah.
from the consumer, I loved it.
Right, well, that's what I'm saying. It it had a lot of good parts, yeah. Right.
Went into the primary care, and the money followed them, and so then the money also followed them when they're really sick.
Right,
And when
yeah.
all of a sudden, suddenly all that was being pulled out.
Yeah, so the risk mechanisms weren't sophisticated enough. I mean, they're more sophisticated now, and then plus there's more tools like electronic health records, et cetera, right? Mm-hmm. Yep.
It's not a paper chart. How
Yep.
do you pull out 1,000 charts and say, let's do our diabetics today with
Right,
paper charts?
right.
Do it.
Yep.
somebody took on more risk than they could handle, they started to really put the screws to people that really didn't need it, and, because they needed to stay afloat. So there wasn't a mechanism to refloat the stocks. And I think we've learned a lot since then. I think that's going to be largely avoidable because it's going to be piecemeal and slow. I mean, to get back to your question about, medications, read that article in Time called Bitter Pill. That plus a whole bunch of other aspects of the medical market. Very much explained. And, the old model is the drug rep comes to your doc's office and gives a lunch and is smooth and try out this new drug. And doc has no risk. And he has no idea what it costs. And he has minimal idea about the evidence base. But his pen is allowed to write for it. You can imagine what that does to expenditure. That's why, the mean insurance guys are out there trying to slow down utilization because docs don't do it. Some think about it. But most, it's just too much trouble. You walk in and you say, I want this new antidepressant I heard about on TV or read about on the internet.
Ask my doctor if this will work for you.
Or my friends
Right.
or my friends on, and they, lucky if they've heard about it, they go look it up online, come back 5 minutes later, show right for it. No risk.
Examples, Cymbalta, that is great medicine. I use it, often for, diabetic neuropathy. I mean, but you'll notice there's also patients that benefit from the same mechanism in Effexor, which is a generic. And I don't know if they ever tried that medicine, but, it's got the norepinephrine, it's got serotonin, and it does have those modulating properties, or amitriptyline, so there are other options that if they were tried may be very effective. And so, the idea is, I know as a select, I worked for Intermountain until last October, they incentivized us to think about that, right? I mean, I used a lot of generics, and I found, though I did love Cymbalta, by the way, it did a lot, I found as I practiced longer and I got more experience, the number of patients I actually had to have on Cymbalta diminished. I got better experience using generic medicines that worked well. And so, those tools, it's amazing as a primary care doc what you can do now with the tools. We've just got Lipitor, we've got Diovan now. I mean, there are powerful tools, pharmacologically wise, that you can use. And it is easy to just write Nexium, the purple pill, because it's smooth name. I mean, it's easy, and people see the commercials. Where omeprazole works pretty dang good. And so it is a hard discussion at times, but getting the providers, and you've got providers seeing 30, 35 patients a day. How much time do they have to sit down and read all those care process models that are sitting on the shelves? They're keeping up. And medical evidence, I think, what is it, 50% of it changes every 7 years. So you've been in practice 7 years,